Bioethics, in which that paper appeared that you see at the top. And then a couple years later, my student Christopher Ostertag and I gave a paper at the American Catholic Philosophical Association, where we started to delve more deeply into how issues of moral complicity, cooperation, and so on relate to what you'll hear me talk about as a compromise proposal. And then finally, I've actually been working with my colleague Abe Brummett, who's on the Zoom today, who will be presenting at this conference on various topics related to conscientious refusals. He's been publishing a number of papers in this regard, and there's a particular issue that I'm still kind of formulating my thinking about that'll appear towards the end that I very much appreciate feedback on. So I think this is a good talk to launch the conference, because the conference theme is conscientious objection healthcare. We have a lot of papers taking diverse different perspectives on this. And what I'm going to do in this talk is sort of set the stage. I will be making a case for my particular take on this debate, but I want to kind of do a lot of groundwork to kind of set things up for forthcoming presentations. So the first thing I want to do is define conscience and its value in medical practice. And then I'll summarize the current views regarding a right to conscientious refusal. And I'll just note here at the outset, I'm going to focus my talk specifically on questions related to conscientious refusals. Of course, especially since the Dobbs decision in the United States, there's been a lot of discussion and debate about conscientious provision of healthcare. I think I know some folks will be talking about that, some of their presentations throughout the weekend. So I'm just going to set that aside for my talk today, even though certainly it can come up in our discussion. And then what I'm going to outline is the criteria for a compromise view based on a set of reasonability criteria regarding conscientious refusals in healthcare, and then raise this fundamental concern about cooperation with punitive moral wrongdoing, and finally end with a call for systemic changes that I think would be needed to licitly enforce the compromise requirements. So when we look at this debate, particularly the literature being put forth by people like Julian Savulescu, Udo Schuckling, Alberto Giablini, and others, they typically characterize conscience in a very sort of reductive sense in subjective or motivist terms, as referring to a set of moral feelings or personal beliefs. And so you have this quote from Savulescu and Schuckling: doctors must put patients' interests ahead of their own integrity. If this leads to feelings of guilty remorse or them dropping out of the profession, so be it. As professionals, doctors have to take responsibility for their feelings. So on this view of conscience, the only criterion for putatively valid claims of conscientious objection is the sincerity or genuineness of one's relevant moral beliefs or feelings, which also kind of tracks with US law about, under our First Amendment, which guarantees freedom of religious expression, which is the basis upon which a lot of the laws that protect conscience are constitutionally framed. That this notion of having sincerely held religious or moral beliefs is kind of the legal criterion there. But the concern that Savulescu and others make is this, allowing these conscientious expressions will open a Pandora's box of idiosyncratic, bigoted, discriminatory medicine. So let me give an alternative view of conscience that, as John Hart and Alistair McIntyre and others have argued, is rooted not in subjective feelings, but in reason and communal practices. And explicitly or implicitly, both Hart and McIntyre are drawing on a notion of conscience formulated by St. Thomas Aquinas. I got to get Aquinas into all my talks, so this is my way of getting him in here. So first of all, I'll be very brief here. For those who aren't fully familiar with Aquinas, I apologize. I'm kind of glossing over a lot of important things. Again, happy to answer questions during the discussion section. So in Aquinas' natural law theory, part of the reason he calls it natural law is that the principles of natural law are discoverable by our natural reasoning capacity. Yes, there are divinely revealed laws that, of course, Aquinas as a Christian believes in, but even those laws are more instructive of things that honestly we should have known ourselves, but because we're too stupid to figure it out, God just had to reveal it to us. That's kind of the idea there. Particularly with the commandments, say, of the second table of the Decalogue, right? Reason should just inform us about the wrongness of murder, adultery, and so on. So what conscience is the application of the general principles of natural law, which tells us things about respecting the fundamental value of life, about the need to preserve justice in our social relationships, about our need to maintain an appropriate relationship vis-a-vis our Creator. And we take those general principles and we apply them to individual cases. And this is, the Aristotelian concept of practical wisdom, right? Phronesis for Aristotle, prudentia for Aquinas, in action. And so conscience formation requires a moral community, right? We're born as moral blank slates. And we need the formation of community, starting with our families, into our school environment, the political societies in which we live. And all this, binds us in a collective epistemic enterprise. It's not quite Rawlsian reflective equilibrium, but there's some affinities, I think, to that notion. Even if one's conscience is in error. So this is a key point. If conscience is what is telling us what is morally right to do, then even if our conscience is in error, there's all sorts of things that can throw our conscience into error, it still binds our action, right? If my conscience tells me to sin, right, the key is I'm not perceiving that action as a sin. I'm perceiving it as a good I ought to do. And I ought to do it. If I were to ignore my conscience and avoid committing the sin because I'm misperceiving it as a good and not as a sin, then I'm saying, oh, here's something that I think my conscience tells me is good, but I'm not going to do it, right? Of course, if I properly perceive what I'm doing as a sin, then my conscience wouldn't tell me to do it, right? So this is why Aquinas says that even an erring conscience binds. So the key takeaway here is that, again, conscience is an all-important factor in exercising human action and employing practical wisdom. It's formable, and it's formable by reason alone, although certainly divine inspiration and intellectual graces have a role to play as well. And it's not just our subjective feelings about what's right or wrong. It's not just our gut. And again, I'm Roman Catholic. Obviously, this is a broader Christian conference, and there's also non-Christians on this Zoom, but I'm going to speak out of my tradition that I know the best, which is the Roman Catholic tradition. And here's just a series of quotes. I'm not going to read through all of these that just show how much, particularly starting with the Second Vatican Council with its statement on the dignity of human beings and religious freedom, on various writings of popes, including John Paul II's encyclical on the splendor of the truth, that give this, elevated importance to the notion of conscience, and that society must not cause us to act against our conscience. And conscience really is our connecting point with the divine mind, with God. It's a very expression of our human dignity as created in the Imago Dei. Now, as we now talk about the value of conscience in healthcare, we need to, first of all, as philosophers always like to point out, it's important how we frame the question. And this is interesting because you see the question, it gets formed in multiple ways, but there's sort of two very broad ways with whatever language they use that I see this question getting formulated. So, for example, some would say, should we allow conscientious refusals by healthcare providers, right? That notion, which you kind of get more from people like Savalescu and Shuklink and others, really thinks about medicine, healthcare, and sort of autonomy-based consumerist model, where healthcare or medical practice is a technical service being provided by physicians. And so it's like, so the foundational premise is, if the customer, i.e. patient, asks for the service and it's legal and falls within the medical standard of care, you, the physician / technician, ought to provide it. And if we are going to allow you to refuse to provide it, right? The burden is on you to make that case for not providing it. Whereas another way of framing the question from those who argue from the other side is something like, should we compel healthcare providers to act contrary to their considered moral judgments, right? This is now putting the primacy about the individual's conscience and then saying the burden of proof is on those who would call for physicians to violate their conscience. By the way, I may just, as a matter of shorthand, say physicians, but obviously this debate covers healthcare providers in a much more broader sense, including nurses and pharmacists. So unless there's a specific example or case, I may say healthcare providers, I may slip and just say physicians, but I'm pretty much intending it across the board. So this latter way of framing the question views medicine, as Pellegrino and David Tomasma and others have argued, as a moral community with its own inherent ends, its own telos, and it's vocational. So those who enter medical practice do so to bind themselves through oath-taking into practicing medicine in a certain way in accord with their conscience. And so again, there may be circumstances that where it is right to compel providers to act contrary to considered moral judgments. We'll get that towards the end. But the burden of proof is on those who would call for that. So again, it's just the way we frame the question kind of pushes the burden of proof to one side or the other. In terms of, again, why conscience is important, it's not important only for respecting the dignity of the individual practitioner, but also for the profession itself, to preserve moral pluralism in the profession. In this article by John Lantos and Farr Curlin, they say, for situations in which disagreement is consistent with good medical practice, practitioners must be free to follow the dictates of conscience. The risks of disallowing conscientious practice to the profession are greater than that of allowing grounded and well-articulated zones of moral pluralism. And you see I have this book posted here by Paul Lombardo, which tells the history of the infamous Buck v. Bell decision in 1927, in which the US Supreme Court upheld the state of Virginia's law that allowed the state to forcibly sterilize a young woman named Carrie Buck against her will, based on the notion that both her mother, who you see pictured, Carrie herself, and Carrie's first child, who was only about 6 months old at this point, were declared imbecilic. And in the majority decision, Justice Oliver Wendell Holmes famously said, 3 generations of imbeciles is enough. Now, for those of you, some of you may or may not be well familiar with the eugenics movement in the late 19th, early 20th centuries, but the idea is that the eugenics movement was a predominant mindset in society, particularly among educated and socioeconomic elites. In medicine, it was very much considered the norm. Now, of course, there are a lot of doctors who didn't participate in sterilizations and who would have refused to if compelled, and no doctors were compelled to. But imagine if, say, physicians were compelled to participate in forced sterilizations. Wouldn't we value those who stood up against that and conscientiously refused to do so? So again, what we consider moral practice and the standard of practice in medicine, what considers good medical practice, shifts and changes over time. And so again, we need this, as Lantos and Curlin say, well-articulated zones of moral pluralism. So now I'm just going to briefly canvass the 3 main views regarding this debate. Again, those of you who are presenting on this or at the conference well know these positions. I'll go pretty quickly here. So first is what I call conscience absolutism, which is basically the notion that a right to refusal ought to be protected based on whatever grounds a practitioner or healthcare institution justifies their refusal. Outside of emergency services in the US, we have this law called EMTALA that requires the provision of emergency care. But otherwise, healthcare professionals have a right to define the scope of their own practice. And when it comes to a lot of the issues at stake, say like with abortion, the right, say, to abortion is a negative right, not to be interfered with by the state to obtain an abortion. It does not entail a positive claim right to provide abortion services. And I'm not a legal scholar, but I did do a kind of quick and dirty survey for one project on abortion laws around the world, and I couldn't find any examples where the law enshrines a positive claim right. Now that is changing in some states in the U.S. after the Dobbs decision, where some state legislators have or in the process of passing state constitutional amendments that actually would enshrine a positive claim right to abortion. So that's just kind of an interesting after effect of the Dobbs decision. I should also note briefly here that, again, I'm not going to get into the weeds on this, but there's a debate within the debate about how we should view institutional conscience, whether only individuals practitioners should have a right to exercise conscientious refusals, or whether healthcare institutions like a Catholic healthcare system or so on should have that. One of the graduates, another graduate of our program here at St. Louis University, Elliot Bedford, wrote his dissertation on that subject, and he's subsequently published an article in National Catholic Bioethicists Quarterly, so I could refer you to his work if anyone's interested in that particular question. So what we often refer to as a compromise view is been articulated by the American Medical Association, by ACOG, which is the American College of Obstetrics and Gynecology, their Committee on Ethics. And again, apologies to international participants for being so Amerocentric, but I got to speak out of what I know, and I don't know all the laws and other things in other countries. And so here, the basic idea is both ACOG and the AMA acknowledge the right to a conscientious refuse, provided these three conditions are met: providing accurate and unbiased information, referring patients to other professionals willing to provide such services, and providing such services in emergency situations. Now, while the first condition may raise the specter of moral complicity, I have not really found a lot of, at least to me, convincing arguments that providing information in and of itself rises to the level of illicit moral cooperation, at least in the framework I'll articulate later. Referrals, on the other hand, present a much more of a moral minefield. And then emergency situations is the one I'm kind of still forming my own thinking on now, and we'll talk about towards the end. Okay, the final position is the incompatibility thesis. Again, this is the position of Savulescu, Shuklink, Jablini, who will be debating with Professor Simons tomorrow morning. I think their position is well known. Doctor's conscience has no place or little place in delivery of modern healthcare. And this goes back again to Savulescu's landmark article in 2006. A quick aside here is that a primary complaint among defenders of the incompatibility thesis is that conscientious refusals are typically based on religious grounds. Shuklink makes this point very clear. Just to read the last line, conscience clauses today are by and large a concession of special rights to Christian healthcare professionals, at least in secular Western democracies. So, and as I said earlier, at least in the US, because of our constitutional protection of freedom of religious expression, that has been the legal basis upon which a lot of the laws that protect conscience rights are sort of take their inspiration from. Now, although it may be descriptively true that most conscientious refusal claims are religiously based, it doesn't follow that such refusals cannot also be given a defensible rationale suitable for the Rawlsian public square. And if we think about, again, speaking of what I know, Roman Catholic objections to directly intended abortion or assisted suicide, the church has made secular arguments for these things. For example, recognizing that a human person's existence arguably begins at conception, that there are reasonable arguments to that effect. I myself wrote a whole book giving a philosophical defense of that view, not a theologically based view. And then the church employs the precautionary principle to say we ought not to risk harming entities, i.e. embryos and fetuses, whose personal status is debated, but who may, in fact, it's reasonable to consider as persons. In terms of assisted suicide, if we look, for example, at Aquinas's sort of tripartite indictment of suicide, the first two of the three reasons he gives is moral duties we have to ourselves, which anticipates a later argument by Immanuel Kant, to one's community, which echoes an argument originally given by Aristotle, and then finally referencing God. And there have been arguments against assisted suicide mounted by secular bioethicists like Daniel Callahan has famous essay, When Self-Determination Runs Amok. So yes, while it may be primarily Christians, as a matter of fact, who are making claims of conscious refusals, they don't necessarily have to make them based on purely faith-based principles. There is a concern here that religiously based conscientious refusals may lead to problematic outcomes, particularly when claimants are not even aware of the rational foundations, if any, for the religious prescriptions to which they are adhering, or they misunderstand or misapply what the religion teaches. I'm going to go deep into this example, but Shooklink, and I personally have called him out on this in correspondence, we're actually friends, he always finds these real life examples of very disturbing misuses of conscience, like this example in Ireland. And I just keep pushing back and saying, yeah, that's a straw person. Not in the sense that didn't happen. I mean, you're right to call out this egregious example, but this is not a typical example of where conscience is being properly applied. And acknowledging that various religious traditions are not necessarily monolithic with respect to different views. As Kate mentioned in the introduction, I edited this book, Contemporary Controversies in Catholic Bioethics, which comprises 34 essays, some written by some of the folks here on the Zoom, like Professor Helen Watt, engaging on 17 different topics where Catholic bioethicists are disagreeing with each other. And so there's a lot of room for discourse, debate on what constitutes the proper application of conscience. So what are the goals of what I'm going to call a reasonable compromise view? First, to recognize the ubiquitous role of conscience in moral deliberation and decision-making. Aquinas says that any act that follows from the human intellect and will, any intentional act that we do, is an act of conscience. Right? Savulescu and Shooklink and Giblini want to carve out conscience-based decisions and actions from non-conscience-based ones. No, every action we do is an exercise of conscience. 2, acknowledge the value of protecting providers and institutions' liberty to act or refuse to act based on reasonable claims of conscience. And there's various reasons to support this beyond what I've already given in our panel at ASBH and that article of Theoretical Medicine and Bioethics. Dan Somasi makes a powerful argument for toleration of pluralistic values within liberal democracies, drawing on John Locke. Avoiding both religious and non-religious comprehensive ideologies. Again, a lot of those who advocate the incompatibility thesis are kind of coming at this from a sort of Rawlsian sense of what constitutes a just society. And they might say, oh, well, these religious comprehensive ideologies don't have a place in secular healthcare. But as my good friend and colleague Abe Brummett, who's on the Zoom, has argued, secular bioethics and medicine itself can constitute a comprehensive ideology, a quasi-religion with its own metaphysical, epistemic, and moral and meta-ethical commitments. So, we may not be able to avoid comprehensive ideologies, but we try to ameliorate their effects as much as possible. And next, not undercutting the availability of non-contested healthcare services by driving providers or institutions out of the profession, right? This is a huge concern if, for example, certain laws were to compel, say, Catholic providers, other Christian providers, Catholic healthcare systems to provide services, right, that they deem unconscionable. They might close their doors and not service, those particularly in rural communities who need access to good healthcare. And then finally, affirming policies that protect individual and institutional conscious refusals to provide services that are generally morally contested on reasonable grounds. Okay. So again, basically my picture of this is we're disallowing purely faith-based claims that are not also grounded in a defensible set of supportive reasons and arguments. I take seriously the concern that Savulescu rates about idiosyncratic, that Pandora's box, right? We're looking for reasonable views of conscious objections. And again, there might be some pushback on that, but that's the position I'm staking out. Disallowing discriminatory claims that target types of patients as opposed to specific actions. One example that, again, Professor Brummett has published on is discrimination in a Catholic hospital against prescribing PrEP, right, HIV prophylaxis, to a bisexual patient. Not because the physician has an objection to prescribing PrEP, but an objection to prescribing PrEP to this particular type of person based on their sexual history, right? And so that'll be another carve out of what's being disallowed on the view that I'm proposing. Maximizing accessibility to services. So a key argument by defenders of the incompatibility thesis is that this is all a way to undermine people's ability to access legal services like abortion and where it's legal assisted suicide. And you know, while those of us who defend the right to conscience often have problems with those moral practices, the goal of a reasonable compromise view is not to end that access. It's not to block access. Now, again, we'll get into the question of to what extent should we facilitate access through referrals and so on, but it's not about simply blocking access. Again, provision in emergency situations, we'll talk about that. And then finally, fostering continued constructive and critical dialogue, which is part of what we're doing here today, particularly with the exchange with Professor Giblini and Professor Simons tomorrow. I already mentioned about spoiler screening. I'm going to kind of speed things up a little bit here. One question is, who adjudicates the reasonability of a claimant's basis for conscientious refusals? Some have proposed that there be some sort of tribunal, like in a military tribunal for conscious objections in the military, but that raises its own questions, right? Who would compose such a tribunal? How would members be appointed? What safeguards would there be against bias? So it doesn't seem like that would be the optimal means, except maybe in unusual cases if someone truly has an idiosyncratic conscience claim. Whereas for services that are widely contested, it's not necessarily that an individual should have to justify their particular claim of conscience, but we just allow for a blanket allowal for conscious refusals for whatever reason. Mishka and Nagelson argue, I think convincingly, for the special status of claims to refrain from intentionally ending a human life, right? This is a fundamental fulcrum upon which the internal morality of medicine turns. Can medicine, as a practice, engage in acts that intentionally end human life, or is that completely outside the boundaries of good medical practice? Because this is such an important foundational debate, it seems like allowing for that type of conscious refusal should just be a blanket allowance. And even if the person's reason for refusal is not something they could personally articulate in a reasonable fashion, right? They haven't studied Thomas Aquinas or read Evangelium Vitae, but in their heart, their conscience tells them this is wrong. This is not good medicine. We should allow for that. So again, just to reiterate, typical compromise requirements, disclosure. On that note, I'll just add that such disclosure should happen early on in the therapeutic relationship. There's a big concern that, again, a lot of hospitals, particularly, say, Catholic hospitals, it's not always known that someone is going to a Catholic hospital, right? Our healthcare system that owns our university hospital is named SSM. Without knowing what SSM stands for, why would anyone think it's Catholic, right? And so, it can be very confusing for patients of whether they're going to a Catholic hospital or not, or without understanding the finer points of Catholicism, besides what they read in the media, what would be allowed or not allowed within a Catholic hospital. Or again, same with an individual physician. If you're an OBGYN who's taking on a new patient and you refuse to do certain acts like elective sterilization or directly intended abortion, you should disclose that, I would argue, up front and say, I'm happy to be your doctor if you understand that these are the conditions under which I practice medicine. This is what I consider to be good medicine. Again, referral, transfer, we'll talk about that more in a minute. But again, I think another key point here is that while a requested service is being refused, that the patient themselves as a person still ought to be respected, that we must avoid stigmatization and outward judgment. So now we get into this issues related to disclosure, referral, and complicity. Does disclosing information that say abortion is an option or assisted suicide is an option where it's legal, or abortion, raise the specter of illicit cooperation. And so just think of an example of employing a hitman. So a friend of yours comes to you, they just found out that their spouse has cheated on them and they want to kill their spouse. And they say, will you help me kill my spouse? And you're like, no, I'm not going to commit murder, but I know this guy, Tony Soprano, he lives down the street. Here's his phone number, call him, right? So you just referred to a fictional hitman to help your friend engage in something that your own conscience wouldn't allow you to do. So regardless of how the law treats this situation, and you actually would be an accomplice to murder and under US law, that's a clear example of illicit cooperation. Now, of course, a key difference between that and the analog in terms of procured abortion or medical assistance in dying, assisted suicide, while there's clear societal consensus that murdering your spouse when they cheat on you is wrong, there's no clear societal consensus on these other actions, right? So there's a disanalogous feature there. But the key lesson I want to draw from the hitman example is that if you are providing your friend with the hitman's contact info, you must at some level approve of your friend's desire to kill their husband, even if you personally wouldn't do the action yourself. And so this is where we get into the weeds of this notion of moral cooperation. Again, this is drawing a lot on the Catholic moral tradition, going back to Thomas Aquinas. I highly recommend this book by Kevin Flannery, continuing through moral theological developments in the 17th century and beyond. And the first key point we need to learn is that we can't avoid cooperating with things we consider to be evil. Archbishop Anthony Fisher from Sydney, Australia says, if we live in the world, we will engage in cooperation from time to time. Indeed, sometimes it is our duty to do so. To avoid all cooperation in evil would require that we abandon almost all arenas of human activity and could well constitute a sin of omission. So it's not that we need to avoid cooperation, it's that we need to analyze the type of cooperation in which we are engaging. So for example, there's formal cooperation, where either implicitly or explicitly, an agent approves of the other's wrongful action, like in the hitman example. That would be clearly illicit cooperation. You would be morally culpable for the action, the ensuing evil that occurs. But then there's material cooperation, where an agent is instrumental in another's wrongful action, but without themselves approving of the action. Now, mere material cooperation may be licit, but it's not always licit, because we have to examine the causal chain of mediating agents between the acting agent and the commission of the wrongful act. So is what you do as the cooperator causally proximate to the commission of the wrongful action? Or is it remote, right? Are there many intervening steps between what you're doing and the evil being done? And immediate material cooperation may be licit. Again, it's not always going to be licit, but it may be licit if there's a proportionate reason for the agent's cooperation. And just to give you a couple of examples, I don't want to spend too much time on them, but some of you may be familiar with the legal battle brought by the Little Sisters of the Poor against the Affordable Care Act, otherwise known as Obamacare in the US, when they instituted a mandate to cover contraceptives as part of an insurance schema. So the Little Sisters of the Poor, as an employer, were compelled to provide, initially, to provide contraceptive coverage for their employees. Well, then a compromise was made where the Little Sisters could opt out by submitting this form called EPSA 700. And then the government would step in with a government-provided insurance that would then provide the contraceptives to their employees. And the Little Sisters fought against this. And while many in the pro-life community have championed their fight in this example, I actually don't think they had a case, morally speaking, because simply by submitting that form on my analysis, along with my student Chris Ostertag's, is that constitutes immediate material cooperation. And so they weren't being compelled to act against their conscience simply by signing a form that opts them out of being involved in the provision of contraceptives, even though they know that now by having submitted this form, some other causal agent, some other entity, i.e. the US government, is going to step in and provide that coverage. Another example is the University of Notre Dame, facing this same situation, decided to actually provide contraceptive coverage for their students, faculty, and staff, because under the insurance that they, Notre Dame, provide, they can provide non-abortifacient contraceptives. Whereas if they also opted out like the Little Sisters, then abortifacient contraceptives could also potentially be provided. So it's basically the toleration of a lesser evil. And that, Chris and I analyze as involving implicit formal cooperation. And this is under presumption within Catholic teaching that any form of contraceptive provision is morally illicit. Of course, other Christians and others don't always agree with that, but that's the analysis from within the Catholic framework. Another concern that comes into play here is scandal. So even if you're justified you have a proportionate reason to engage in immediate material cooperation, there's still the risk that by having done something that is morally permissible for you to do, you have created a situation in which you might induce others to sin, either actively because you actually intend to scandalize someone else, to actually warp their conscience, misinform it such that they do something sinful, or maybe much more ubiquitous, passive scandal, when you don't intend to lead another to sin, and what you do doesn't by nature lead someone into sin, and yet the other person is led into sin as a result of having witnessed your particular action. So this is often the concern that are raised by Catholic bishops in the US when certain issues come to the fore in Catholic healthcare. So for example, while it is clearly allowed by the ethical and religious directives for Catholic healthcare services, some Catholic hospitals or individual providers will still conscientiously refuse to provide emergency contraception to a victim of sexual assault. Again, it is allowed. The US bishops have been clear on that, but the concern, at least by some of these institutions and these providers, is it could scandalize people into thinking that, oh, the church is just okay with it with contraception now. No, it's okay with emergency contraception under certain specified conditions as a treatment to avoid pregnancy in the case of sexual assault, right? But the concern is that, well, the wider public doesn't understand all these nuances and the media will throw headlines up, and that concern is certainly valid. Things that are supposed to be nuanced often get promoted in the media, or especially on social media now, in various straw person type of ways. So that's where the concern of scandal comes in, is that you may be justified in what you're doing in terms of the type of cooperation you're engaging in, but you may still be causing some sort of public scandal here. So again, as I said before, applying this analysis, mere disclosure does not necessarily entail formal cooperation. Referrals are a bit different, particularly in terms of how various healthcare systems are set up. And one of the things that Chris Ostertag and I do in our papers, we distinguish between referring to a physician or a group that's known to provide the objective to service, say like Planned Parenthood, versus just referring to, well, go see some other doctor. And that other doctor may or may not provide the service. I don't know. I'm just saying I'm not going to provide the service, and as your primary care provider, I'm authorizing you to go see another physician and see if you can find someone who provides that service. That's sort of on you. That's kind of the way of putting it. But what would be even better, on my view, is if we adopted some sort of systemic changes to take the burden off the individual conscience of the healthcare provider. So for example, when medical assistance in dying, as they call it in Canada, was legalized, every province had to come up with their own legislation and create their own framework for providing MAID. And what was written into Ontario's legislation, although to my knowledge it has not still been implemented, is basically an MAID hotline. If you're an Ontario resident and you want to avail yourself of assisted suicide, you just call this hotline, so to speak, or it's probably a website, and there's a list of willing providers. And of course, the way the Canadian healthcare system is set up, you don't need, to, go to your physician and get a referral and all those things for insurance purposes. You just go to the doctor who will provide the service, and you don't have to worry about, going to someone whose conscience may not allow them to provide that service. Again, well, this is basically saying a lot of things that I just said. Depending on the healthcare system, the degree of control that one has and the necessity of one's referral to access for a patient access a service plays a role in determining whether you're engaging in implicit formal cooperation, immediate material cooperation, or mediate material cooperation. Again, when it comes to scandal, it's also likewise nuanced. In cases involving merely mediate material cooperation, the act of referral constitutes, I would argue, merely passive scandal, since the inducement of another to sin is clearly outside both the referring provider's intention and the nature of the act performed. If the referral constitutes formal cooperation, so say a physician employed by a Catholic hospital who publicly morally approves of abortion, then that physician would be engaged in an active scandal. And it's important to keep in mind that, there's a value in maintaining as best we can the relationship between the physician or the healthcare institution and the patients who are requesting the services, even when conscientious refusal is being invoked, by witnessing to moral truth, by not simply telling the patient, oh, I can't provide you the service, you go somewhere else, but by using this opportunity to say, well, I don't provide this service, here are my reasons why. If you still want the service, then yes, you need to go elsewhere. Now, some people are concerned about this invoking proselytism or so on, but some legal frameworks that, or arguments for adopting certain legal frameworks where physicians are conscious and refuse actually require physicians to give reasons to the patient and not simply dismiss them. So again, that can be a positive opportunity for witness. And here, and I'm getting towards the conclusion here, when we think about witnessing and the way in which we sort of navigate these complexities, Archbishop Fisher again draws a distinction between kind of two ways of thinking about this with, again, a sort of Christian framework. He says, there's the prophetic witness who presumes against cooperation, even materially, insofar as morality is part of the vocation to human perfection. And this offers a distinctly Christian form of witness to the life of God's kingdom. Whereas what he calls the tax lawyer are those who regard the moral law as a series of constraints on human freedom. And we find a way around and utilize, again, ambiguous concepts like proportionate reason, common good, and so on, to try and do or cooperate in doing things that are objectively morally wrong. Now, again, this is the same prelate who earlier said we can't really avoid cooperation if we're going to live in the world. But he gives us two frameworks, these two almost extremes of using cooperation frameworks to work around and of almost avoiding cooperation frameworks to be that prophetic witness. As a sort of challenge to Fisher's view, Catholic theologian Kathleen Kavanagh presents a different framework, Pilgrims on the Way to the New Jerusalem, that because the kingdom of God has been inaugurated, was not yet fully realized, we must respond to the suffering that results from the effects of sin that is still in our midst. We must, while the prophetic witness emphasizes the risks and dangers of cooperating with evil, the pilgrim highlights the good that such cooperation can accomplish. In the context of healthcare, prophetic witness might voluntarily go out of business rather than cooperate. So this is the concern of Catholic hospitals shuttering their doors if they're pushed in certain directions to actually require to give active effective referrals or so on. But removing Catholic healthcare risks losing sight of the corporal work of mercy, which is a fundamental moral obligation. To combat the culture of death, we must witness to the value of human life and the means of supporting life by providing healthcare. And we got to also consider the effect that closing the doors would have on access for the most vulnerable, which is often where you find Catholic healthcare in a lot of underserved areas. So final thing I'll just bring up very, very quickly and move into discussion. Something that I've still been personally wrestling with, I've been, Abe Brumman and I have been discussing a lot, is this question about emergency provision of objectionable services. So what if, again, your conscience tells you providing, say, an emergency abortion? So this is, those of you who may be familiar with what's known as the Phoenix case. This is a case in which you have a woman who is high-risk pregnancy and is predicted, which is much medical certainty as we can have, right? It's never an absolute certainty, that she will not survive this pregnancy. And not only that, she won't even survive till the fetus reaches the stage of vulnerability, right? The fetus is about 11 weeks along. And so, viewing another, 3 months to get the fetus viable was also not medically predicted. And so at a Catholic hospital in Phoenix, Arizona, therapeutic abortion was performed, right? And the word therapeutic doesn't change the moral nature of the act, that it was a directly intended abortion. And those involved, is the famous case where those involved were excommunicated, later reconciled to the church. But it's cases like that in mind that a lot of Catholic and other Christian ethicists have approached this issue of vital conflicts, right? Life for a life. Or in this case, we're either going to lose 2 lives or we're going to lose 1 life. And of course, we're not being consequentialist about it, so we're not simply saying 1 life, 2 life, but in the understanding that, yes, this is a directly intended abortion. Yes, conscience tells one that one ought to not do directly intended abortions. In an emergency situation, isn't there a role for epistemic humility with respect to one's own moral viewpoint? Again, moral certainty, as Aristotle points out, especially when we're talking about particular cases, is not as certain as mathematical or scientific or logical certainty. So there's a call when confronted with these types of emergency cases to say, my conscience tells me this is wrong, but there's no general societal consensus favoring that conclusion. There's a life at stake here. Maybe I need to acknowledge that I might be wrong, right? So this is, sort of a taper on conscience in these particular types of contexts. So finally, like I said earlier, I think a lot of what we need to do in calling for systemic changes is to take the burden off the individual provider's conscience, and those who are concerned about access to these legal services need to use the state to invest in guaranteeing that access to such services. We also need to think about different ways in which we can engage in preventive acts like appropriate sex education, access to non-abortifacient contraceptives. Of course, again, for Catholics and some other Christians, that in itself is problematic, but for others, it's not. Or maybe at the very least, it's a lesser evil worth being tolerated to reduce requests for abortion. Invest in high-quality palliative care and hospice services to reduce requests for assisted suicide. And then finally, to enforce extant requirements and limitations on conscientious refusals. Like I said, a lot of the cases that those who promote the incompatibility thesis will point to, again, these are real cases, they're not just making them up, but they are a bit straw person cases, because they're cases in which the person themselves didn't exercise conscience appropriately. So for example, this case that my colleague Mike Redinger points out of a Catholic pharmacist refusing to fulfill a prescription for methotrexate for a woman who had an in utero loss of fetus, right? She miscarried and the fetus was still inside, and to avoid sepsis and so on as the fetus's body decomposed, she needed to get that out. Her doctor prescribes the drug to get that. Sorry, it was mifepristone, not methotrexate, mifepristone. And the Catholic pharmacist, because mifepristone is also an abortifacient drug, wouldn't fulfill the prescription. And so, as Mike Redinger says, this Catholic pharmacist didn't even get Catholic medical ethics right. So I think that's one of the best ways of combating what's arming these incompatibility arguments is, yeah, we need to hold those who invoke conscience accountable for not misapplying it. And with that, I will end, and I think we got about 20 minutes for discussion or so.
Thanks very much, Jason. That was a fantastic, erudite, robust, comprehensive presentation, and we're very grateful once again for for you joining us this year as our keynote speaker for the 2023 Society for Christian Bioethics conference. We've got about 20 minutes for questions. May I suggest that we run this by raising one's hand if you wish to ask a question, and there'll be a queue based on at what time you raised your hand. And then we shall also, like if you wish, make comments in the chat. That's fine as well. Please be once again respectful and thoughtful in your comments, and brief ideally. But in terms of questions, please raise your hand. So we'll go first to Abe Brummett, who has I see raised his hand.
Hey Jason, thanks for all that. I wanted to ask about the distinction that you led with about like how we define conscience, because I get a lot of I frequently get questions from like reviewers when I write papers like, well, what do you mean by conscience? Like, you know, do you have this subjective, more subjectivist interpretation or the more objectivist interpretation? And my thought on this has always been like, who cares what I mean? Like, because a lot, you know, what does it matter, you know, whether I have a subjective or an objective interpretation, especially given that a lot of conscience law doesn't make this distinction at all. It just says like, is it a core moral or religious value, full stop, not also and formed objectively via, you know, the natural law in a community. But it's like, you know, we have no use for that. And I think the reason why I am concerned about this question and why I want to say it doesn't matter is because a lot of my work is on defending, you know, what I call secular conscience in medicine, which, you know, it doesn't have the robust history and tradition that, like, you know, the Catholic view of conscience has. So, you know, that's part of what's motivating me to want to say, you know, sort of who cares about this question, and only ask, like, is it a core moral or religious value? Yes. Okay, now let's proceed with the analysis.
Yeah, thanks, Abe, for that question. And again, for all your work in this area. So I think part of the reason the distinction is important to highlight is that, first of all, I just think the subjective is used wrong. I don't think anyone just has feelings about conscience. I think I think conscience just is our exercise of practical reason, and we can't act without employing practical reason. So whether, yeah, it's the sort of, whether we have a thick description of what that means in terms of a Thomistic natural law theory or Aristotelian theory of practical reasoning, or it's just a secular notion of engaging in, you know, and you know, this is just one example of thinking about you know, Rawlsian reflective equilibrium practice, right? It's still employing reasoning. And my concern is that, again, you have this kind of straw person set up by Shooklink and others of saying, oh, conscience is feelings, and then there's reason, and reason should be our guide. And I'm just saying that, well, conscience is reasoning, and it's not just feelings. So I actually agree with you. It shouldn't make a difference. And what we mean by conscience should always be, it's an exercise of practical reason. However we define what that means in an Aristotelian, Thomistic, Rawlsian sense, that it's never just, oh, I feel this way. I mean, one might have a emotive reaction about their conscientious feelings, right? Might feel disgusted by the thought of having to do. That's why we talk about moral distress, right? And moral tragedy, right? Like some Kate's work on, you know, this area. So not saying there can't be a feeling associated with, but the incompatibilists just want to reduce conscience to just a set of feelings. And I'm saying, no, it can't be that. So I think it's important to highlight that distinction for that reason.
Thanks very much, both of you. So just, Andy, would you like to ask a question?
First of all, thank you for this talk. I think it raises a lot of really interesting worries. So my question is, how do you square apparent conflicts of, shall we say, conscience and duty, or how one takes their duty to be? I'm thinking about your hitman example. That might be, I'm going to tweak it, right? Because I'm not sure that anyone has such a duty, but suppose a soldier in wartime. Obviously, I think most people have a conscious or a conscience that objects to killing, but you might think that you have a duty to your country or your countrymen or just your friends who are next to you. And so, though your conscience tells you that this is wrong, your sense of duty motivates you to act anyway. And I think there are analogies to how that might manifest in healthcare, right? You might have, like for example, in the Phoenix case, right? You might have a duty to act, or understand your duty to act in a certain way that you find unsavory or even wrong, but you also feel this, this internal conflict. How should we mediate between those two, in a dilemma like that?
Yeah, thank you very much, Andy. This is a great follow-up to Abe's question, actually, because again, the way I understand conscience in the Thomistic sense is that, again, while our conscience obviously can be in error, our conscience can never tell us to do something that we actually think is wrong. That is just logically impossible, right? It's internally contradictory. Now, our conscience might tell us to do something that disturbs us, that makes us feel sick to our stomach, that is going to traumatize us and we lose sleep over, that we wish we were in a better situation that we didn't have to do that. But so go back to your soldier example, again, assuming a framework that this is a just war, that this particular killing is just in bello, that yeah, anyone should be, we would hope, should be disturbed by the thought of taking another human life. But if they truly think that their duty to their country compels them to do this, or to protect their own life in a combat situation, then that's their conscience telling them to do that. Their conscience is not at war with itself. Their conscience is only at war with actually their subjective feelings of disgust, that they shouldn't be in this situation, right? So yes, our conscience, I think, can compel us to do things that disturb us, but it can't compel us to do things that are actually wrong. I don't think that conflict can actually arise.
Thanks. So I might jump in and ask a question. Jason, one of the things I found particularly helpful about your presentation was I think you provided quite a detailed exploration of formal and material cooperation in evil. And I know I'm not an expert on this topic, so that was quite helpful. And I'm looking forward to reading Kevin Flannery's book on that topic. I did have a question similar to what Helen Watt has asked. It will just comment on in the chat. So I am intrigued about whether intention should play a more dominant role in our account of cooperation in wrongdoing than a notion of approval, insofar as I suppose my thinking is the moral character of the act seems to be fundamental rather than so much like the attitude we adopt to what we do, or kind of some sort of like second order attitude we adopt to what we do. Once again, not an expert, but asking, more just for clarificatory purposes. Thank you.
Yeah, no, thanks for that, and also Helen for your comment in the chat. Yeah, obviously I've limited time for a presentation, and this is just but one part of it. And as again, if you read Bob Flannery's book and others, these are very complex things. And Flannery actually disagrees, say, with Alphonsus Liguori, who's the moral theologian who kind of is taken to be given us this framework. But Flannery thinks he gets it wrong, actually. So one thing I would say in terms of the like the distinction between explicit and implicit, I think when it's explicit, I think that does involve some level of subjective approval. So I think in the hitman example, the person who's asked to help the other kill their spouse, they can't bring themselves to do it, right? They don't want to commit murder. They might just fear legal reprisals for doing so. But they give the referral to the hitman because they do want, they're like, that sucks that your spouse cheated on you. I want them dead too, right? So I think at some level, that's the full level, the highest level of cooperation, where you're all but doing the deed yourself for whatever reason you decide not to do it, but you're going to help make sure the deed gets done. Implicit is a little different, and I do agree that the intentionality separates from the approval. So go back to the Notre Dame example. So this is an example that, again, Chris Ostertag and I assess as involving implicit formal cooperation, not because, you know, the administrators at Notre Dame who approved this plan approved people having access to contraceptives, right, per church teaching. They should not approve of that, but they accept it and tolerate it as a necessary means to avoid what, you know, they judge, you know, rightly to be the greater evil of people having access to abortifacient contraceptives. So now they can control and only allow access to non-abortifacient contraceptives. And but they can't avoid implicitly formally cooperating with people gaining access to non-abortifacient contraceptives, right? That's the cooperation involved there. So yeah, you're right. It doesn't necessarily have to require approval, but it is, yeah, part of the intention of the act that in that particular case, people have access to those types of contraceptives.
Hey, did you want to jump in there with a question?
Thanks so much. This was really great. Just a really great way to start everything. So thank you. I have a question about what you were calling the straw man arguments of the people reasoning wrongly about their conscientious objection. Because it seems, or I'm not sure what we're supposed to do with that, I guess, because it seems like if we have a really strong sense of conscientious objection, we're just going to have to allow that sometimes people take a stance that seems wrong to us, but that's what conscientious objection is. And sure, something like the Catholic bioethics example, you know, we can pair it up with a tradition or something to maybe say, well, they're, you know, in contradiction with the tradition they're claiming to be part of, but maybe they could just also come to reason it in a different direction. Or anyway, it just seems like maybe we should just let people also have I don't really understand how they can do it wrongly, or maybe we should just allow for that. So I'd like to hear more of your thoughts. Thanks.
Yeah, no, thank you, Kate. Yeah, I mean, I'm a philosopher, I'm not a policy guy, but of course, all of this, you know, leads to the question of, okay, how do we craft policies to control for potential abuses of conscientious invocation, which is a concern of mine. And I guess the question is, on which side should we err? So for example, with something like the pharmacist refusing to fulfill the prescription for mifepristone, which I should note, in that particular case, the pharmacist not only refused to fulfill the prescription, they held on to the prescription and would not give it back to the woman. And so she had to go back to her doctor to get another, right? And again, the concern about, as fetal demise is happening in utero, that she could develop a very serious bacterial infection, right, as a result, and her life be threatened. Thankfully, as far as I know, that she turned out it was fine. She got the mifepristone eventually, and everything was okay. So it's really, you know, I see Ann Williams, you know, in the chat noting about, you know, freedom, right? So what's the more important value when these types of cases, since particularly in the vital conflict cases, freedom or life, right? And again, that's where I think we do need some sort of, you know, epistemic humility about maybe erring on the side of life versus erring on the side of one's freedom to not do an action that they might judge to be life-ending, because of course this could have been a prescription. She could have been deceiving him. I mean, the part of the issue with this case too is that the pharmacist is like challenging her. So like, well, why do you need this? And in public, like this is like at a CVS or a Walgreens, right? Imagine you're standing in line at Walgreens being, you know, getting the third degree by this pharmacist about why you need this drug. And you explain to them, oh, I had a still, you know, I have, you know, however she explained it, I got a dead baby inside me, I need to get it out. And the pharmacist saying, well, I'm still not going to give this to you, right? There, you know, at least I would argue the freedom of the pharmacist. And actually my colleague, Mike Redinger, who's a physician himself, he has an interesting take on this. He thinks that physicians should have wider latitudes on conscience, and other types of providers like pharmacists should have much less. He doesn't think the pharmacist should be questioning the physician's writing of the prescription, just fill the prescription. Yeah, that, I'm sure there'll be a lot of disagreement with him on that, but that's, part of the complexities of this. And so again, when it comes to public policy, when it comes to say, should we maximize freedom for people to act on their conscience, even if their conscience is erring? Again, we go back to Aquinas, the importance of acting on an erring conscience. Or when there is a more public good at stake. So another place that I think I've been writing about, and I won't get into this whole thing for the sake of time, but what about conscientious refusals to be vaccinated for COVID-19 back when the vaccines are first rolling out, right? I argued in several different publications that, at least for Catholics, qua Catholics, that they didn't have a basis to conscientiously object, even if they had some, potentially legitimate concerns that the public health good of attaining herd immunity and so on through a mix of vaccination and infection and so on outweighed those individual, notions. Now, again, you need a high bar, which plenty have argued that we didn't achieve, of epistemic certainty, prudential certainty, that mandating something like that, that overriding someone's conscience would actually lead to the public good being attained. But that's the framework in which I think we need to approach this. So I know it's probably not a satisfying answer to the question, because the question you asked is, I think, much bigger. It would take a whole nother talk to address that. But I do think we do need to think about, so how do we actually craft policy to control and for legitimate exercise of the conscience versus why would deem illegitimate exercises of conscience? And we probably do just have to tolerate that there's going to be some of the latter for sure.
Go to Anthony.
Yeah, hi, thanks. Good morning. I'm Anthony Weiss. I'm a physician in Boston. I really enjoyed your talk. Appreciate the thought that went into it. This is more of an opinion question, I guess. From where I sit, as healthcare becomes increasingly secular, I've seen a kind of paradox where we're seeing more professionals, nurses and physicians raising the concept of moral distress relative to their work. But it seems that these claims are often related either to having to maintain the life of a patient that they don't feel is worth continuing to maintain, or completely devoid from that, something where the professional doesn't feel like they can carry out their professional duties given throughput pressures or other economic pressures on them. These claims seem distinct from religious-based conscientious objection, and I'm interested in your perspective as to whether this increase in statements of moral distress are actually beneficial to those who have religious-based conscientious objection claims, or whether you think it's causing a watering down effect of what is actually moral or immoral.
Mm-hmm. Yeah, thank you very much for that question. It kind of goes back to Andy Baldassarre's question about, again, so moral distress. So first of all, we need to distinguish, and I know a lot of you are familiar with the distinction, but for sake of those who aren't, right, emotional distress from moral distress, right? There's all sorts of actions which one might be forced to do in medical practice that are emotionally distressing, right? But that they're completely morally legitimate to do, and the person's conscience is not bothered by them. They knew, again, the soldier has to kill to do their duty. It's not that their conscience should be bothered, but their emotional state is. Whereas moral distress is when you're either compelled to do something or you refrain from doing something that your conscience tells you is morally you ought to do or ought to refrain from doing. And that's the cause of moral distress. So I do think there can be easily a conflation between those two things, right? And so we do need to distinguish those. And then even in the context of moral distress, right? Again, we are called to follow our conscience, but again, we also have the epistemic humility to realize our conscience may be in error. And so when someone is making a moral distress claim, I think such claims, can be legitimate. We ought to take them seriously and respect them. But I think there's also responsibility on that person to examine their own conscience and to say, is what's bothering me truly something immoral, or am I just getting sort of disgusted by it? And it also then ties into this question that Kate and others have worked on. One of my own students, Julie Gunby, is working on this now, probably for her dissertation, on the concept of true moral tragedy. So in something like the Phoenix case, Julie is arguing that what was done, this directly intended abortion, and she's pro-life, this directly intended abortion was both wrong, but also not doing it would have been wrong. That you can't actually avoid the wrongness of it. Now, in reviewing her work, I've constantly pushed back on her because as a Thomist, I actually do believe there is ultimately a right answer to those questions. There may be emotional, sequelae of having done the right thing, and your conscience subjectively might not be too clear on which was the right thing. But I do think from a God's eye perspective, there was a right or a wrong of what was done or not done. And so, we're operating within that realm of epistemic uncertainty about moral matters. So to go back finally, to the point, so a nurse who's say compelled to provide, fetal care, fetal treatment for a patient, and that is bothering them and making them feel like they're being made complicit and materially, instrumentally causal with, maintaining the life of a patient who's suffering when the patient should be, and maybe has even requested to be allowed to die, just to be, let nature take its course. That, again, that can be a legitimate claim of moral distress. But at the same time, that nurse should still be reflecting on, okay, am I seeing the situation correctly? How well formed is my conscience about this? Depending on their religious tradition, what do I understand what my tradition says about this? And of course, Catholicism, we have, there's still a lot of intra-Catholic debate. There's also still a lot of things that are pretty much settled for Catholics. But most other religious traditions, it's, a lot more open. And if you ask a particular reverend or a particular imam or a particular rabbi, you'll get different answers. Which then can lead to a situation, maybe the opposite of the case of unavoidable moral tragedy, of just of moral rightness, that maybe whichever action you do, you're justified in doing it. And there is, in something like the Phoenix case, actually no moral wrong. You'd be justified in not doing the abortion, you'd be justified in doing the abortion. So it can go maybe cut both ways.
Thanks very much for those questions, everyone. And I'm sure you'd all join me in thanking Jason for a very informative and thoughtful, comprehensive overview of this topic of conscientious objection in healthcare. It's a wonderful way to start this conference. So thanks again, Jason, for a fantastic presentation. So we are going to take a 15-minute break. So we're returning at 10:30. In about 5 minutes, I'm going to set up 2 Zoom breakout rooms, one for stream 1 and one for stream 2. So we have 2 streams. We have a stream on pandemic ethics, and we have a stream on wellbeing, body modification, pediatric care. So you can choose between one of the 2 streams, and we will commence again at 10:30. So feel free to leave any questions you may have in the chat, and I'll be back at this computer in 3 minutes, so I'll be able to answer them then. Thanks again, Jason, for a fantastic keynote, and I'll see you all in a second.
Thank you all. Really appreciate the questions and comments.